So to start with, I want you to tell me that question. 65-year-old patient with an MI has a blood pressure of 140/80 on atenolol, LDL of 3 on atorvastatin. So what are you going to do? You've got various options. First of all, leave on atenolol, he's 140/80, or add something. Any thoughts? Who will leave him alone? See you next time. See you next time.
It's non-diabetic.
This one's non-diabetic, yeah.
She's not diabetic.
This one's not diabetic.
Okay, I do an HbA1c.
Okay, that is a good. That's correct, but that's not on the MCQ. That wouldn't work. But never mind. You've only got two options. I want to know who will give him something or will just leave him alone, and ask you the evidence. Okay, you give him an ACE inhibitor. Okay. Okay, let me just show you what it is. This is the first of the papers that you haven't read is the SPRINT study. Okay. And it's a really interesting study. They basically took people exactly in that position who were on a statin and had a high risk, they had an MI in the past, and they randomized them basically to another drug, less than 120, or left them alone at 140. Okay, they're the two options. And they followed them for a period, okay? And their primary outcome was the usual major adverse cardiac events. And they looked at those outcomes in secondary, death from any cause. And they said that they basically said to optimize those who needed the higher drug, they encouraged but don't mandate those with the strongest evidence for reduction in disease, basically thiazides, beta blockers, etc. Okay, and some were encouraged, but they let them do what they like. So it's a real, what they call one of the real world studies. Okay, and at 1 year, the mean blood pressure in the treatment group was 121, so they've done pretty well. And in the non-intensive group, 136. And they carried on for 3.5 years. And then they found there was a significantly lower rate of primary outcomes in those with the intensive treatment. So a very brief summary, this is what I'm getting through super quickly, is that it makes a difference. And you can see there, so there's a key summary. 9,000 people with a blood pressure over 130, with a significant risk of MIs, either 120 or 140 was your plan, and look at the difference. Okay, you can see it's magnified up there, but there is a significant difference between the standard group and the treatment group. If you look, if I could get the mouse out, it's very small in real terms. There it is. So this is magnified up with the numbers down here being, up to 0.1, 10%. But it's significant, and therefore, I think a reasonable message is we need to treat blood pressure more aggressively. So when you see a patient in clinic, and in diabetes that makes it even worse, but if they run at 140, the tendency to say, let's see how it goes, check it again, think about it, white hypertension, we miss a trick. We miss the chance to do something about it and improve outcomes.
And certainly in a black population, the thiazides are very, very good.
Yeah. Yeah.
So they'd excluded diabetics in this study.
In this study, yes, but anyway, we'll. Okay, now I want to just talk a bit about different studies. So we need to think about what that really means. So here is the thing magnified up, and I'll put in my own editions the difference there. So 10% versus 8%, which is advertised as a 20% relative risk reduction, but I'd like to stick to absolute reduction there for 2%, which means if you give 100 people a thiazide, you will prevent 2 deaths. Okay, that's pretty cheap. I mean, it's very cheap because it's a thiazide. So that's really good value and a really good study, okay? And it's called the SPRINT, and those are the outcomes. Any questions about that?
How did they measure blood pressure? Was it a 24-hour or just a one-off in clinic?
It was a several off in clinic, but it was not a 24-hour.
It was a sitting down, sort of automated machine.
Yes.
Omni.
Yeah. I don't know what it's called, but it was standardized, but it wasn't a 24-hour. So that's what we do. If we check blood pressure in clinic, we should do something about it. And 140 surprised people. I mean, I was surprised, to be honest, that this made a difference. But it does. So look at that.
Do you react to a single blood pressure you check?
No, you don't. Yeah.
That's my point. That's their point. We see people in clinic, and then we do nothing about it. We spend £100 for the outpatient appointment, and then we do nothing.
Well, apart from the fact I intentionally often do nothing, because then they say to me, I'm really worried about my parking, it's about to run out, or I've run here, and the bus was late. And often when I find that the blood pressure doesn't
this is
necessarily
for
be
blood
representative.
pressure.
Well, you don't know that. These
Well,
people
that's
all
the
have
thing,
this.
I
This is
don't know.
a real world
The blood
study.
pressure ought to be managed in general practice, where the nurses do the blood pressure and they'll have 3 in a row.
Yes, I
And
agree
they've
with
got
you,
the
actually.
time to get them relaxed. A lot of patients buy their own Omron, you know, £40 on Amazon.
We all ignore it a bit,
They
don't
can
we?
take-
Okay, and then this is definitely cause again 7% down to 5%. So again, if you give 100 people a thiazide, you'll save 2 lives, an absolute reduction. The papers always quote the relative risk reduction, the RRR, but I think that's a bit misleading because it looks like things are fantastic.
It looks very good.
But actually, even 2 per 100 is, I think, good. And I'm telling you that because I'm going to tell you another paper in a minute. So there's no spin there, okay? It's a real paper. It's got real evidence, good outcomes, and basically 100 people with cardiac disease, you will save 2 lives over 5 years if you give, according to the SPRINT study, treatment. Okay, and so to summarise, really, we should optimise treatment. Aspirin, statins, blood pressure control, and thiazides are so cheap that it makes them very good value. And as Anne said, we should assess them for type 2 diabetes. Let's put that in there, because that's
And we
absolutely...
should encourage the practice does the blood pressure.
Yeah. Okay.
Anyway, or because of the thiazide? No, you're just saying.
Can I just say that where do you get the evidence for the aspirin?
Yes, that's come
Yes,
out.
that's
Take you through the stage, okay, which is he's now on his thiazide. His LDL is 3, and he's on atorvastatin 80, remember, and then thoughts about further lipid lowering. And your options are many, okay, and I want to briefly cover the last of those, the evolocumab, because
I'm so sorry, he was on a atorvastatin 80.
yes, with an LDL of 3. I want to show you some numbers. Yeah,
Can we just
some
ask,
mechanisms. Yeah.
Jane something for a minute? Would you
Yes,
mind?
of course. No,
Jane
go ahead.
Ryan.
Yeah.
I'm just looking at Jane
Yeah.
Ryan.
Anyway, this a bit about PCSK9 inhibition. There's the LDL receptor, and there's a protein called PCSK9 on it, and basically it recycles the receptor. And if you can give an antibody to that protein, you can drop the LDL to crazy low levels, like 1. Isn't that amazing? 1.3. Compared to standard therapy of the statin. So that's what would happen if we gave this patient evolocumab, a monoclonal antibody against the PCSK9 protein. So here is a randomized study, okay, published in the English Journal only 3 months ago, and they looked at the outcomes of evolocumab in patients with CV disease. And they, I think, did something quite good, which is they chose patients who were already on a statin and therefore had a low risk to their cost, really, of having problems. So that was that said, to test whether the addition of evolocumab reduces the risk further, basically, and to investigate the usual stuff they say in these studies of lowering LDL-C. Unprecedented low levels of LDL-C. Big study, 27,000 patients, okay, who had an MI or a stroke or symptoms, screen them, stabilize them with a statin, had a placebo run-in, and then basically randomize them to evolocumab or placebo on top of their current treatment. So to start off, that's American units. So in the UK units, it's 1.8, and non-HDL of 2.6, and then not very, very long follow-up, okay? And they looked for those primary endpoints, the usual CV death, MI stroke. Hospitalization is a slightly unusual primary endpoint, okay, because they usually include all-cause mortality as well. So it's a slightly different for some reason. So rehospitalization for intervention, basically, was another endpoint. And then there's the usual thing about safety, efficacy, and looked at risk of diabetes.
Okay.
And it was more than 1.8 was the cut-off for LDL.
To get in, yeah.
Which is quite tight, actually.
And it was a very big international study, lots of countries around the world, 49 countries, okay, over essentially 3 years. So enormous study, enormous expense for the company. And then they follow them up for just over 2 years.
I don't mean to interrupt. Can you just go back to your map? I seem to see Hungary in Africa.
No. yeah, there's their differences. So 13,000 in each group, okay, followed for over 2 years. 2,000 had a primary endpoint and 1,800 had key secondary endpoints. Remember, that includes being in hospital. And very, very small numbers left, and very few. It was a really good study in terms of keeping all the people in, okay? And very few left during the study. And if you look at the beta characteristics, they had an event in the past, and they had a lot of hypertension and diabetes and smokers. 3/4 were male. I'll put the UK numbers on the left because that's how they came out. But basically, 2.3, 4.3, and 1.1 were the LDL, cholesterol, and HDL on entry, as you say, really low. Yeah. And then look at this. They brought the LDL down to 0.8. Okay. And the placebo were 2.3. So enormous risk reduction, or rather level reduction, aiming for some hoped risk reduction with evolocumab. So fantastically low levels of LDL cholesterol, 0.8. And there's the difference over 3 years, okay? But this is the primary endpoint, which includes revascularization. So again, 2% over 3 years, that's 150 to treat, to reduce the risk of death, MI, stroke, or hospitalization for revascularization. Okay, that's 14% relative risk reduction. And if you look at the secondary endpoint, which is death, MI, or stroke, then it's 9.9 against 2% overall over 3 years. Okay, so the relative risk reduction is 20%. So 9.9 to 7.9. So that looks reasonable. But if you then look at them together, you'll notice that there's no actual difference at all in the cardiovascular death rate at all. It's 1.05. So 2.5 versus 2.4 deaths in the drug compared to placebo. So it looks like it's not even close in terms of mortality. So it looks like the difference is due to other causes rather than death from MI, or an MI that doesn't kill you, a non-fatal MI, in other words, is the big difference.
I guess it's, it's 2-year follow-up. If you think about, LDL lowering, was it
2 and a bit years.
It takes a while for your LDL lowering to actually have an impact on your arteries, I guess, doesn't it? My impression was that the further they got into that 2 years, the
You're absolutely right. You are absolutely right, okay? And let's see what they've tried to do. They've said exactly as you've said, just a bit secondary endpoint first of all, okay? 9.9 to 7.9, okay, over that period. But just to look at this, right? If you look at the death rate, it's not different. I made that line up. That was my addition. They're only quoting that top bit there, but the actual death difference was 0. Okay, no effect on death. And this is them then coming back. If you read the paper, it says, well, actually, there are no other studies showing any benefit over a statin, and here are all the other studies that are equally negative. And so it's still a good drug if you want to use any of the other drugs. Okay. And then they did something really is exactly as you said. This is in their paper. They've said perhaps the benefit is delayed. Okay, so minor effect in year 1. But look, as years 2 and 3, if you start again in year 2, or call that 0, you can bring out a difference. So as they say, maybe it's better in the longer term. But that's not evidence-based, really. That's just slightly cheating. Yeah. So there, what do you think? Is that spin? Fake news? Benefit of benefit? Just a thought, really.
How many events were there? How many deaths were there?
I think it was 20-something.
There's tiny numbers as well.
Well, yes, absolutely. The number of deaths was small because, of course, they were already on a statin and had a low LDL, so they were very well managed. They were a quite low-risk group. But the question is important. Is this because the cost is enormous? Is it worth spending the money?
How much is it?
I've got it coming up. Side effects, no difference. Just briefly, I have got the costs on the slide. Okay, No concerns. They make a big point saying, well, this drug doesn't cause diabetes, unlike statins. But they still make it look good, okay? In patients with known disease, PCSK9 inhibition with evolocumab significantly reduces major cardiovascular events when added to statin therapy, but not death. And
Any side effects though?
no, the side effects were exactly the same, so no difference in side effects.
So it's interesting they don't get rhabdomyolysis, so it suggests that the effect of statins is not lipid lowering per se. It's interesting, isn't it?
Well, there's another effect of statins, certainly.
Sorry?
No, I always thought that the myositis and...
Hang on.
We were just quiet, Julie, for a minute.
You were really quiet.
We were just
No.
thinking.
Okay,
that's all.
so what they say is all true, but if you look at the risk reduction in a relative manner, okay, relatively it's 20% risk reduction, but the absolute reduction is very small, 0.7% per annum, and if you need to treat 150,000 people, that's £600,000, or as the New Zealand says, $1 million, okay? And that's for no effect in death. So is it worth spending all this money compared to the statins, which, as you say, are dirt cheap? And it's going to be tricky, I think, to justify in large groups. Now, do you know what they've done already? They say aches and pains really bad. There's a huge push to encourage people to know about
Lots of patients asking about
aches
it
and pains.
having to break the news that obviously they're not going to
They're not going to get.
going to qualify for it because NICE obviously would never.
Yes, well, they're hoping. They're hoping that
numbers needed to treat.
they're hoping they come up with
Pains don't happen, do they, after that?
the nocebo effect, exactly. So that's the other thing to bear in mind. There we go. So that's his conclusion. Okay. Now, I think we want to keep using them for patients who are high risk, maybe statin intolerant, which is what the drug companies want. I think familial hypercholesterolemia groups need good control, and that might be the group that you treat.
And it might be, I mean, erythropoiesis is very expensive.
Yes. So
And
if you're going for that,
you can only have it in certain centres in the country.
so this is the BMJ's view that followed, okay, and it's quite interesting to read this. The future cardiology happened at 1 o'clock on Friday, 17th of March. This when the results of the Fourier trial were announced. The BBC immediately declared a massive breakthrough. Many American commentators sprang into action. It would take $2 million. It would take $2 million or more to avoid one event in a high population over 2 years. The effect on all mortality was 0 or worse. They could see the future, and it was pants that cost $15,000 per year per person. Anyway, and of course, it's all this BMJ thing is all about how glitzy the whole thing was and how they managed to put a positive spin. And the usual, we need to do more trials, longer trials, etc. So, in terms of finance, this is a drug that's going to be difficult to justify for most patients, and the company's going to push us to give people who say they're intolerant of statins, and that's going to be a grey area. No.
It has to be in highly specialised tertiary clinics who know what they're doing.
I mean, the company has sort of bit themselves in the thumb a little bit because they've costed it so high.
And he says, well, think about that, okay? Does not reduce death, bear that in mind. But let me tell you about another success story, and that's, of course, the SGLT2 inhibitors. All of you will have seen this EMPA-REG. I'm going to summarise it to compare the numbers rather than anything, okay? And just briefly, you remember that it makes you pee out sodium and glucose, and therefore your blood glucose falls because you exceed the new renal threshold of glucose. So here's the study in EMPA-REG. They took a large number of people and randomized them to placebo, EMPA-10 or EMPA-25, and the same endpoint, MACE, major adverse cardiac events, and they analysed the whole lot in a very similar way, in fact, to the other studies. And the A1C fell by 0.4%. The blood pressure fell by 4%, 4 millimeters. So as you say, it's a diuretic effect. Both systolic and diastolic, they lost weight because they're peeing glucose, their waist circumference fell, but their heart rate, thankfully, or perhaps, didn't change. So I think that's quite an interesting bit of data on that slide. And of course, this is the statement that everyone knows, that there was a significant fall in major adverse cardiac events by 14% from about 14 to about 11, okay? So that's the real numbers, 3% reduction over 4 years. But what is really interesting about this is when the improvement starts. It starts really early. Now, if you look at most drugs that help with diabetes, your blood sugar falls, you then wait several years, like UKPDS, and after a long time, you see the benefits. This benefit was really, really quick. Within the first 6 months, it was diverging, and by the end, big difference in death rate, and mainly heart failure death rate. Okay, so it looks effective, and if you look at all of the markers, you can see that it's beneficial in many, but especially cardiovascular death, and in patients with heart failure, it's a bigger benefit. Okay, so this is being hospitalized for heart failure. Look how early that change happens. So, as many of you know, this is probably a diuretic effect, but it's effective. And this is a heart failure data, just comparing it, showing how beneficial it is if you've already got heart failure to start with. So that's a good treat. And then looking at renal function, that's interesting with this renal function, because it seems to be a benefit. And if you look at the actual level, this is from another paper that is from EMPA-REG, but you can see that when you start empagliflozin, the GFR immediately falls compared to the placebo group. But if you wait for a year, you're in the same place, and then the benefits accrue. So that's exactly the same as ACE inhibition, the shape. You start with an ACE inhibitor, your creatinine goes up immediately, and we all have a bit of a panic. But if you keep going, the benefits persist. So it is another drug that you should persist, even if the renal function seems to get a tiny bit worse. Don't have too much of a panic unless it gets much worse. And where that cutoff is always a worry.
There's not massive differences.
Exactly.
Okay.
Exactly. How does it work? We don't know. Okay, it could be many of these things. Probably diuretic effect. Probably weight loss. All these things make you more sensitive. So, 40% risk reduction, but huge effect on death rate, unlike the antibody to PCSK9, and the number need to treat is £48,000 for each death. That's 100, okay, which is 10 times cheaper than the PCSK9 inhibitions, and it benefits heart failure, and it seems to protect your kidneys as well in the long run. Okay, so our friend says,
ha ha ha. It does improve HbA1c.
It does.
So the
That's
reduction
absolutely.
in, the micro.
Of some other known studies. Okay, so liraglutide was similar in terms of event changes, small, but within 5 years, changes in events. Okay, and if you look at all these studies, this is LEADER, which is the liraglutide study, and they then showed highly significant reduction. Small numbers though, but probably very similar in terms of outcome to EMPA. Here's another glutide that did a similar sort of change. So, in terms of diabetes treatment, there are a number of options, okay? And of course, we want to treat them aggressively, but maybe we should be using EMPA or liraglutide in patients who've got vascular disease ahead of gliclazide, glibenclamide, and pioglitazone, and maybe even the DPP-4 inhibitors. But they're the two that seem to really be the ones that change death, which is why we're doing all this. And, this is the standard comparison of all different drugs, but do you not think that maybe we should actually highlight those two as the two that really change mortality, the SGLT2 inhibitors and the GLP-1 agonists, over the others? I mean, that's the question, really.
SGLT2 is becoming second line to first add.